Thanks for joining this CLL Patient Expert Q&A. I'm Dr. Nadia Khan from Fox Chase Cancer Center, and I'm looking forward to answering your questions. Let's get started.
Dr. Khan, first of all, thank you for being part of this program.
Thank you so much for inviting me to participate.
We have a question from Larry about side effects. Larry says, I've been fighting side effects with each medicine. Will the correct answer for side effects in CLL always be to stop the medicine?
Larry, thank you for your question. It is an excellent one, and this is something that we encounter on a very regular basis in our CLL patients who are on targeted therapies. The side effects occur frequently in patients taking BTK inhibitors, in patients taking PI3K inhibitors, and we have some side effects reported on BCL2 inhibitors as well. Typically, side effects on all of these targeted therapies can be managed with either dose reduction or supportive therapies. And we don't necessarily have to stop a medication due to a side effect that is encountered. And of course, it would depend on the type of side effect and the severity of the side effect before deciding to pause therapy for a time or to dose reduce or add other medications to help.
Sarah has a question about side effects. How can I tell if side effects are from CLL, my medicine, or just a part of aging?
Thanks for that question, Sarah. It can be a challenge to tease out the cause of any given complaint, whether the symptom is due to underlying other medical conditions, the medications a patient is on, their CLL therapy, their CLL itself is something that we find to be challenging. And it can often be a process of elimination and understanding when side effects started and how they are related to the known side effect profile of a therapy is often a starting point. Depending on the side effect, we may decide to institute a treatment holiday. And if the side effect improves or resolves during the treatment holiday, it's more clear that the side effect is due to the medication in question. If the side effect persists during that period of time, then it's more likely to be due to something else.
George asks, are there any long-term side effect risks for CLL patients?
That's a great question, George. It really would depend on the therapy being instituted. And when in the chemoimmunotherapy era for CLL patients, we had a very different perspective of what short-term and long-term side effects were and are for those patients who have been treated with chemoimmunotherapy. For patients treated with targeted therapies and immunotherapy combinations today, there tends to be fewer serious long-term side effects. When looking at the various drug classes, for example, BTK inhibitors, there is a risk of atrial fibrillation that remains constant throughout the course of therapy. And if a patient is on therapy for 1 year or 10 years, they can develop that particular side effect. High blood pressure can be significant with BTK inhibitors as well. And that risk also tends to be stable. In terms of infection risk, there is relative immunosuppression with all CLL therapeutics. And so our concern more recently has been focused on COVID infection. Serious bacterial and viral infections tend to be less frequent. We don't institute prophylaxis for those infections because they tend to be so few and far between in the patients that we've treated.
Thank you, Dr. Khan. Here's a question from Richard. I am a CLL patient currently on watch and wait. When is the right time and what tests should have been performed before seeing a CLL specialist?
Richard, thank you for your excellent question. There are a number of tests with respect to CLL that help us to prognosticate more accurately. And those would include either a FISH panel fluorescence in situ hybridization for CLL, which identifies the most common amplifications and deletions that have been described in CLL. Additionally, an IgVH mutational test and a TP53 sequencing test would be the three basic prognostic tests used to identify what kind of CLL a patient has. This testing should be repeated at any point wherein a patient is changing therapy or at any point where there's a change in the clinical status of the patient. Outside of these standard tests, there are other molecular tests that can be ordered and are commercially available for use by clinicians. These molecular tests can also identify changes within the CLL that can help to prognosticate. At this time, outside of the standard tests that I mentioned to you, there are no there's no proven benefit to other testing, but the results of additional testing can just really help inform your clinician about the likelihood of you needing treatment in the near future and the likelihood of response to therapy.
This question comes from Lori. How common is it for CLL patients to develop a second gene mutation?
Lori, thanks for that question. It is not common for most CLL patients to have significant alterations in the genetic landscape of the CLL. With that being said, there are a few notable exceptions. For a CLL with TP53 dysfunction or complex cytogenetics, there is a higher likelihood that there will be genetic instability in those CLL clones. Therefore, it's important to retest for changes if there is a change in the biology of the CLL, if there is progression on therapy, for example, or at the time when a new therapy is planned.
Yolanda's question is, what is CAR T therapy and who is eligible?
Thank you, Yolanda. This is a question that I get asked very frequently. CAR T therapy is an exciting cellular therapy that has been FDA approved in a number of lymphomas, and it is currently not FDA approved for patients with CLL. So at this time, CLL patients can receive CAR T therapy in the setting of a clinical trial only. And it is typically reserved for those patients who have progressed or relapsed after multiple lines of therapy and for whom there is no alternative therapy for consideration. Often it is considered in the context of a clinical trial prior to the use of allogeneic stem cell transplant, because the results of allotransplant and CAR T seem to be fairly comparable. CAR T therapy, however, is much better tolerated than allotransplant. Both of these modalities are very rarely employed for our CLL patient today because of the very effective targeted therapies and immunotherapies that we have to use.
Dr. Khan, Chuck's question is, what are the side effects of CAR T cell therapy?
Thank you, Chuck, for your excellent question. CAR T therapy is associated with two main types of side effects. One is cytokine release syndrome, or CRS, which happens within the first 2 weeks of receiving CAR cells. And that can manifest as fevers, chills, a drop in blood pressure, shortness of breath, and the requirement of oxygen. When that happens to patients, there are medications that are given to help improve those cytokine-mediated events. Another major side effect with CAR T therapy is neurotoxicity, which also happens within the first 14 days in some patients who receive CAR therapy. And that can manifest as anything from a headache to more concerning confusion, seizures, and coma. CRS happens commonly in patients who receive CAR T therapy and is usually managed very successfully with anti-inflammatory therapies given intravenously in the hospital, and can be used for patients even who get outpatient CAR T therapy. When patients do suffer with neurotoxicities, intravenous therapies are also employed to combat that. And when necessary, patients might require escalation to an intensive care setting when these toxicities are very severe.
Dr. Khan, is CAR T therapy a cure for CLL?
Thank you for your question, Bernard. CAR T therapy has been curative for a minority of patients who have been treated with CARs on clinical trials. And unlike other lymphomas, in CLL, there hasn't been an FDA approval as yet for CAR T therapy. And we are hopeful for that to change in the future as CARs are modified and may potentially become more effective at eradicating the CLL, and hopefully resulting in better side effect profiles in patients who do receive CAR T therapy. The majority of patients who have received CARs in CLL studies have not had durable remissions, unfortunately.
Dr. Khan, what is conditioning therapy and why is it given prior to infusion of the CAR T cells?
Thank you, Samuel. Conditioning therapy is a briefer course of chemotherapy that's given just prior to CAR T therapy, really to prepare the body in a way to receive the CARs. And it makes the CARs more effective when there has been a level of immunosuppression to allow the CARs to expand more freely after they have been reinfused into a patient.
Okay, here's a question that Sandra asked. I'm preparing for CLL treatment. Can I take my vitamins, herbs, or other supplements during treatment?
Thanks for that excellent question, Sandra. It's so important to review all of your medications with your provider before starting any therapy during the course of your CLL treatment. Drug-drug interactions with herbals and other over-the-counter medications can result in serious side effects. Some over-the-counters and herbals can inhibit the effectiveness of CLL therapy. So it's important to discuss these with your provider on a case-by-case basis.
Dr. Khan, here's a question that I think many probably are thinking of right now. What tests do you give patients to see if CLL treatment is working?
Thank you, Jessica. During the course of CLL treatments and at the end of a time-limited treatment course, we're assessing for responses. So as a patient is going through their treatment, we may decide to re-image to determine if there has been debulking of lymph nodes. And depending on the treatment that we're administering and where the lymph nodes are located, we may decide to do imaging sooner or later. So for example, if there are palpable lymph nodes while a patient is on therapy, and we can measure these readily by physical exam in the clinic, we may not feel as compelled to re-image at an early time point. If there is bulky adenopathy or an enlarged spleen that is hard to palpate, and we want to understand if treatment is working after approximately 3 to 4 cycles of therapy, we would assess for a good response to treatment if clinically it also does appear that patients are responding. And if there was any question as to response, we would image at an earlier time point. When patients are being treated with a venetoclax-based regimen and there is significant adenopathy or enlarged spleen, we may reassess the size of lymph nodes and spleen during the course of venetoclax ramp-up to determine if patients can be transitioned from inpatient to outpatient ramp-up.
Okay, Dr. Khan, this is our final question. Karen asks, with many new therapies available, will watch and wait be redefined for CLL patients?
What an excellent question, Karen. Currently, the strategy for CLL patients is to institute therapy when there is likely to be a benefit with the intervention. And there are studies that are ongoing looking at earlier intervention with oral therapy. And once we see the readout for patients with particularly high-risk features, I think it is possible that we'll have an alternative strategy for those patients. Thankfully, our CLL patients live very long lives. And what we've come to see over decades of treatment experience with our CLL patients is that early intervention to date has not resulted in longer survival. So at this point, it's not something that's recommended, but we may have more information soon.
Dr. Khan, thanks for joining us today and answering all of these questions for our audience. Just a reminder to our audience, please take the CLL patient expert Q&A survey following this webinar. Dr. Khan, before we end this program, what are you optimistic about for the future of CLL?
I'm very optimistic about the future of CLL therapeutics. We've already come to see excellent responses that are very durable with time-limited targeted therapy and immunotherapy approaches. In the future, it is likely that we will be using a more personalized approach to treating any given CLL patient, using their genetic and molecular profile to decide on their treatment strategy. A single agent approach versus multiple targeted therapies to eradicate CLL clones. And in the future, we'll be looking at endpoints like minimal residual disease, as well as clonal evolution to help guide our treatment strategy for patients with CLL. Thanks for joining the CLL Patient Expert Q&A. I hope this program was helpful. See you next time.